Good morning, everybody. And my name is Peter Turner. I'm the managing partner at Meyers Roman Friedberg Lewis, and I'd like to thank you for joining us and welcome you to this latest in our installment of breakfast briefings. I think we hit a hot topic here just based on the turnout, being health care reform, employer challenges under the Affordable Care Act. And most of us, myself included, know probably just enough to be dangerous about this legislation. And the hope today is that we're going to get some information from some very knowledgeable and informed individuals to help guide us through some of the potential issues that we're going to be facing. It's actually the Patient Protection and Affordable Care Act of 2010, otherwise known as the Affordable Care Act and more commonly known as Obamacare. Everybody's got opinions on what they've heard and what they know about it, a lot of it from the media, a lot of it maybe from self-study. The legislation was passed by the Senate on December 24, 2009. It's hard to believe that much time has passed. It made it through the House on March 21, 2010. President Obama signed it into law on March 23, 2010. And then we all know it was upheld by the United States Supreme Court on June 28th last year, 2012. So in one form or another, it's here to stay. There's some implementation that's about to start. I'm sure you'll be hearing about that. Some of it's been delayed. Maybe there's chaos, but again, we need to get some clarity, and our speakers will help us with that. Very briefly, I just want to give some bios on our panel. It's a very distinguished panel. The first speaker will be John Friend, who's a senior vice president with the Fedeli Group and the head of its employee benefits division. John earned a Bachelor's of Business Administration degree from Kent State University. His employment experience includes underwriting, claims management, preferred provider network management, and development and training in all technical aspects of employee benefits programs. And by the way, I understand, I actually downloaded the act the other day. It's 974 pages long. The implementing regulations are, you couldn't even begin to count them. And John may be one of the few people who's actually probably read it all. So he's a good resource. My partner, Mario Fazio, is the chair of our firm's tax practice and a member of our business and corporate practice group. He'll be the second speaker. In addition to a law degree from Case Western Reserve University, Mario has a master's in taxation from Case Western Reserve University. He's a certified specialist in federal taxation law, and among his past experience, he's a former IRS chief counsel attorney. So Mario brings a very good perspective and can kind of see things sometimes from the government's perspective and bring that to the table. And finally, Mike Stefanek, a CPA, is a partner with BSB Partners CPAs and Business Advisors. Mike earned his BSBA in accounting from John Carroll University. In his practice, he advises clients regarding strategic planning matters, succession planning issues, financial statement reporting, transactional due diligence matters, and general business advisory services. So he kind of covers the waterfront, does a lot of guidance for his clients. And also here with us on the panel, and will be involved in if questions come up, is John Bonfiglio. And John also, a CPA, is a partner with BSB Partners CPAs and Business Advisors. John obtained his degree in accounting magna cum laude from Baldwin Wallace and a summa cum laude graduate with a master's in accounting with a concentration on taxation from CWRU, Case Western Reserve's Weatherhead School of Management. John leads the business, accounting, and advisory services area of practice at BSB Partners and has extensive experience advising clients on financial, business, and tax issues facing today's business owners and entrepreneurs. One other thing I do need to mention, I know you've all got some brochures and some items in front of you. Please take an opportunity to look at the brochure. Meyers Roman is a general practice firm located just down Chagrin Boulevard, responding to all of your business and personal needs. And lastly, for the CPAs amongst us, you are eligible for continuing legal education credits for attending today's presentation. On the way out, Sarah Cox, who is our marketing coordinator, will have a certificate for you, and we're going to end, by the way, the goal is to end no later than 9:30, so everybody can plan on that. So we've started 8 o'clock to 9:30, and the accountants will get for that 8 to 9:30, and how they do this is beyond me, but 2 hours of continuing education credit. So with that, I'll turn it over to John.
Thank you, Peter. That's great. Good morning, everyone. Peter just told us a little bit about when this law was passed. So the law was passed, and then it was challenged in the Supreme Court. And during that Supreme Court challenge, I was actually on a very expensive vacation in Hawaii that my wife had planned and frankly overspent for radically. And then I found out the law was going to be affirmed. And I thought, okay, we all have to stop eating and drinking now because I'm going to be unemployed within the next 12 months because we thought everything's going to the government. Well, that hasn't happened. I'm glad to still be employed. Hopefully we'll have another Hawaii vacation at some point in time. However, the government's role in health care has continued to increase since the passage of the Medicare-Medicaid Act back in the 60s. I was talking to Barb this morning, and we talked a little bit about we're all going to survive this law. We're all going to have a lot of consternation while it's done. When Medicare was passed, it was a revolutionary intervention by the government in health care, really. It was the government now becoming a payer of bills in the health care space. When ERISA was passed, we all thought, oh my goodness, what's going to happen? Businesses won't survive. Less so with COBRA. We had COBRA passed, and again, now we're saying we got to continue to provide benefits to employees who don't work for us anymore. That was ludicrous. Then we had HIPAA. Again, HIPAA was an interesting law. It created all kinds of havoc in our businesses, but we're all surviving it. Medicare Part D came along. Again, similar consternation. Employers, what's my involvement? What does creditable coverage mean? What does all this stuff? But we survived it. And I promise you we will survive the Affordable Care Act. So for those of you that are concerned, confused, wondering what the heck's going on, hopefully we're going to shed a little bit of light on that for you today. But I promise you we will survive the Affordable Care Act. Let's talk about access to health insurance today. 55.3% of us get our health coverage. And I'm saying coverage because the payment mechanism, obviously, typically we transfer that risk either to an insurance company or through a self-insured plan. But 55.3% of us get our health insurance or health care paid for by an employer-based plan. 15.9% is Medicaid. 14.5% is Medicare. Yes, there are still 16% of us that don't have insurance. This act was really directed at many of those people who either don't have access to or don't have the ability to afford insurance. The Affordable Care Act, as it's called, isn't really that, but we're working on it. And then obviously 9.8% of us are either individuals or small businesses who buy it in the individual marketplace. The Affordable Care Act is going to radically impact the individual marketplace as well. So as you can see, still the vast majority of us get our health insurance or health care paid for through an employer-based plan. That is going to change pretty radically with the aging of the baby boomers into the Medicare generation. So this pie chart's going to look very, very different in 2020. Where'd it go? There it is. It's always good to see the United States at the top. Not so much in this case. Healthcare spending per capita in the U.S., right around $8,000. If you look at us compared to all the other countries, anybody good at flag recognition? We got Germany and Korea and Sweden and some others up there. We lead the pack, but not necessarily in a good way. If you look at GDP per capita, we're pretty productive as a country, not quite the most productive, but as a ratio of GDP to what we spend, we are by far and away the highest. Is that a good thing or a bad thing? Well, we don't have the best results in healthcare, as everybody knows, but we have pretty good results. Morbidity and mortality in America continue to decrease, but we have some pretty significant health issues that we have to get after. I think every single presentation that everybody gives should have a call to action. I'm going to have a call to action for all of you in this room by the end of the presentation, but it really is going to be around something I like to call personal responsibility. Every one of us have a responsibility to do the best we can, not just for ourselves, but for our employees, those of us that are employers, and for our really fellow human beings. Obesity in the United States is pushing 35%. 16.1% of us smoke. We deliver a lot of imaging. Anybody in the room not ever had a CAT scan or an MRI? If you've never had a CAT scan or an MRI, please raise your hand. Look around. 3/4 of the room has received some very expensive imaging. I had my son in the ER literally on Sunday. He's a football player, went down, little injury. First thing they do when you roll into the doors of the ER is, oh, we got to get a CAT scan. Being in the business that I'm in, I pushed back and said, can we get an x-ray first? They did reluctantly agree to the x-ray, which, by the way, was inconclusive, and they had to do the CAT scan anyway. Good news, CAT scan was negative. He's fine. He's got to sit out a week, but he'll be back. The challenges that we face, obviously, are many of them are very controllable and very driven by lifestyles that we choose to live as Americans. Again, obesity is probably the #1 health issue right alongside of smoking. As you can see in the rest of those flags that you saw up there are organized through something called the OECD, the Organized Economic Council for Development. Statistics not nearly as dire in other places, although smoking is still pretty rampant in Europe. They like to smoke over there. But as you can see, most of these statistics, life expectancy at age 65, so we're living about 20 years. The rest of the world's living 20 and a half, not substantially different. So we're getting essentially the same result, but we're spending a whole bunch more money here in America to do it. So I would propose that reform is necessary. Not a huge fan of how it was done, but again, I promise we will get through it. Just real quick, Peter kind of told us a little bit about this already, but March 23rd, 2010, the law was signed. June 28th, when I was in Hawaii with my family, the Supreme Court ruled. I got depressed. July 22nd, the Treasury announcement came out that we were going to begin the implementation process. We were all racing forward for this magical date of January 1st, 2014, at which time all of us as employers, big or small, have new things to deal with, new responsibilities. And then all of a sudden, just about a month ago, the administration put the brakes on pretty hard and said, yeah, it's not fair, it's not ready, let's put off what we call the shared responsibility piece of the law. That's the part that says you as a large employer must sponsor a health insurance plan or pay a tax, and you as an employee must purchase insurance or pay a tax, you as an American citizen. That part, guys, has not been delayed. So there is a responsibility. Everybody in the room, if you're a citizen of the United States, and if you're a legal alien here, must have health insurance January 1, 2014. Whether you get it through your employer, whether you get it through a public or a private exchange, we're going to talk about both of those here today, you must have insurance. But you as an employer of over 50 employees do not have a responsibility until January 1, 2015 to offer health insurance. We've got a variety of things that have happened inside the law, most of which right now are pretty innocuous. President Obama, every time he gets on a podium like this, likes to talk about all the wonderful things that the law has done. I would propose that the law has done very little for anybody at this point. If you're a kid age 26, yes, you can stay on mom and dad's plan. Very, very few people age 26 were insured on their own anyway, and very few of them need health care because that's the young, healthy generation. So has it helped? Sure, it's helped for some folks who graduated from college and maybe there wasn't a job available to them so they could get onto an employer-sponsored plan. 2013, we have W-2 reporting. We have a new thing called PCORI, which is the Patient-Centered Outcomes Research Institute. The government, in their wisdom, said as part of the law, they should research the efficacy of the law. Let's think about that. We already know the law's not working all that well. Maybe we should put an institute together and make the good taxpayers of America pay for it. Sorry for my political state there. PCORI is a pretty small fee. It's $1 for every belly button on your health plan. It's going to be collected for you by your insurance companies. If you're self-insured, you may have to remit that directly. 2014, the big news is in, what are we, the 18th of today, so 12 days from today, all of you will be able to go out onto the public exchange and shop for your insurance. I was talking to one of our guests here today, and he said he went out onto the exchange, and he's a pretty educated guy, frankly, a CPA with probably advanced degrees, and he couldn't figure out how to do it. So the good news is that consternation that I had back in Hawaii about I'm going to be unemployed, it's pretty confusing. I think we're okay. We're going to need to help everybody. But as of October 1st, the public exchange comes online. Our good governor decided that Ohio would not, Ohio would not sponsor our own state-based exchange. We'll talk about that in just a few minutes. So we're going to have a federally sponsored public exchange. Guys, it's not the federal government providing your insurance on this exchange. It's the private insurance companies from which you already purchase insurance Medical Mutual, Anthem. United Healthcare has actually taken a pass on the public exchange for now. They're going to enter into it later. But it's the same insurance companies. If you're buying employer-based coverage, you're going to be buying it from the same folks. The rates and costs are going to be nearly identical to that you'll receive if you purchase it privately. The big difference is if you're participating in a public exchange, again, in Ohio, a federal exchange, you'll have access to subsidies. Real quickly, the individual mandate. If you choose not to follow the law as of January 1, 2014, you'll have to pay a tax. That tax starts at $95 per year or 1% of your income. So let's say you're a person making $45,000 a year. We're talking about $450 a year as a penalty tax. Anybody want to venture to guess the average monthly premium for an individual? Shout it out. Around $450, $500 a month. That's what we're expecting the exchange to be for a person in their kind of mid-30s. So the conundrum then becomes, okay, I'm an American citizen, the law says I have to be insured, but I'm young and I'm healthy and I'm currently not insured. Am I going to go out and spend $7,000 or $8,000 a year to avoid $450 in taxes? Probably not. So we don't think that there's going to be a major rush for those young, healthy, uninsured folks to go out and get insured. What we do think is there's going to be a huge rush for the not so young, not so healthy, uninsured who can't get insurance today to rush out to the exchanges. We're going to have something called anti-selection, where folks who need it really badly start to buy it because they've never been able to get it before. That's going to be one of the concerns. Shared responsibility, as we talked about, has been delayed. However, I think most people have attended or read or seen, it's pretty significant if you choose not to sponsor an employee-based health plan and you're over 50 employees. It's a $2,000 tax or possibly a $3,000 tax if your plan is deemed to be unaffordable. As an individual, you have to maintain what's called a bronze plan. What in the world does that mean? Well, it gets complicated. The bronze plan is based on something called a 60% actuarial value. Do we have any actuaries in the room? Good, because I like to talk bad about actuaries. Actuarial value, basically, if you think about $1 million of cost going into a plan, a 60% actuarial value would essentially be, in broad terms, 60% of that $1 million would be covered by the health plan. So you have to maintain a plan as an employee or an individual that has a 60% actuarial value. You as an employer, if you're over 50 employees, have to sponsor a plan with a 60% actuarial. Again, approximately 60% of the expense of the health insurance or health care costs borne by the plan. We're not going to go into much minimum value, but the government has actually gone so far as to stipulate what must be covered in the health plan. So some of you may have casual employees or part-timers where you said, hey, we'll provide you a mini-med or a hospital indemnity plan. Those plans don't meet the minimums. So many of them, as a matter of fact, Aetna, large insurance company, has exited that business because they don't think too many folks are going to buy it. As we just talked, if you're over 50 employees, you have a responsibility to provide employee benefits to your employees or pay a tax. Many of the employers out there saying, okay, right now, we just saw that the costs for Americans is $8,000 a year for health care. I know as an employer, when I get my bill every month, it's a lot more than $2,000 a year. Why wouldn't every employer just say, I'm out, and go ahead and pay the tax and push their employees into the public exchange? I think the reason many employers that I'm talking to, and frankly I've talked to all of my clients at this point numerous times about this law, and with the exception of one, first time I heard it, nobody is anticipating abandoning the health insurance programs that they have now, because I think there's a lot of uncertainty, and there's this whole idea of trying to attract and retain good people. And I can imagine an interview going something like, you've got the best and brightest, you've got a young John Bonfiglio coming out of his master's degree program at the Weatherhead School of Business, and you say, hey, we really want you to come to work for us here at BSB. Tell me about your benefit plan. Well, that's a good question. We do the public exchange, and we're going to give you a couple $1,000s into your paycheck, and we're going to go ahead and pay a tax on your behalf. I'm going on Deloitte Touche because Deloitte Touche is going to offer me a better benefit plan. So I think, again, a lot of employers who want to attract and retain good people recognize this is a way to separate yourselves. So I don't see wholesale adoption of the public exchange by too many employers. If you're under 50, the mandate doesn't apply, so I think we'll see more of those kinds of employers considering their options. The last thing we want to talk about it with regards to the shared responsibility again, which is delayed, is the 9.5% rule. So the original legislation said that if you offer insurance to your employees, not only do you have to offer a minimum plan, it has to cover things like outpatient and inpatient and emergency room and prescription drugs and a whole host of things that it has to cover. It also has to be affordable. And they decided that affordability was 9.5% of an individual's income. And it actually started of 9.5% of family income, right? So about 2 months into the law, they realized, how in the world are these good employers going to know what the spouses of their employees make or potentially what the family's income is? So they deferred back to saying, okay, it's 9.5% of individual income. So first of all, they kind of wavered, but the other thing I want you to think about is 9.5% of your individual income, in the government's wisdom, they've decided you should pay 10%, roughly 10% of what you make towards health care, right? If you're borrowing on a mortgage, they do about a 25% debt to income ratio, so you can spend up to 25% of what you make on housing, right? They allow that for your mortgage. Now they're saying 10% of what you make is going to be spent on health care. That's a pretty scary number to me. There we talk about the 60% actuarial value. We're going to move on through that. So the last kind of little nuance, anybody in the room have more than 200 employees? All right, if you have more than 200 employees, as of 2015, you have to automatically enroll them in the health plan. That's the law. We're going to see some guidance. That doesn't take effect until the end of 2014. Now let's talk about transition fiscal relief. Obviously, this law is going to cost a lot of money. We're going to talk about the taxes and the revenue generation from our friends at BSB. We're going to talk about employer responsibilities as well. Employer exchanges. So there's two kinds of exchanges today. Anybody read the news that Walgreens, that was in the news this morning, actually, I think Mike sent it to me. Walgreens is now going to move into a private exchange, different than a public exchange. Public exchanges offer government subsidies. Private exchanges, and really right now we've got two very large retailers that have moved into that space. The first was Sears/Kmart. I think we all know Kmart and Sears are owned by the same holding company. They adopted a private exchange very early. Now Walgreens is doing that as well. The health insurance world is moving very quickly towards something called defined contribution. Anybody have a defined contribution pension plan? A 401k, right? So when we all grew up and our parents worked for Ford or GM or a large company, they had something called a defined benefit plan. They would retire and they would get a set amount of money per month. Many of your folks may be retired now. Some of you in the room may still have a defined benefit plan. But because of the aging of America, because of the poor performance of the market, because of some actuarial statistics, we've moved away from defined benefit plans by and large towards something called a defined contribution plan. Many of us, probably the vast majority of us in this room, our pension is going to be from a defined contribution 401k plan. Health insurance is moving very much the same place. So these private exchanges will be based on a financial model called defined contribution, very much like the defined contribution in your pension plan. Employers will say, okay, here's what I can afford to pay on a monthly or a quarterly or annual basis for your health care. You, as an employee, will be needing to pay the rest. Again, we defer back to that 9.5% of your income. Let's say your employer pays half of that. Now we're fortunate that we may be only going to pay 5% of our income, our gross income, towards this. So today, public exchanges are a conduit for a subsidy, but private exchanges, there is no subsidy. We are continuing to hear that there may be some subsidies available for folks to participate in private exchanges, but as of now, the only way to get a subsidy is to participate in a public exchange. We talked about bronze. There's two other metal plans, silver and gold, as you might guess, as well as there's platinum. Very few employers are going to be offering a platinum plan, but bronze, silver, and gold will be the standard upon which all the plans will be judged. The bronze plan we talked about, 60% actuarial equivalent. Silver will be a 70% actuarial equivalent. Gold will be 80%, and then platinum would be 90%. Let's take a quick look at the subsidies because they're fairly significant. Again, our friends from BSB are going to talk about the revenue generation side of this. This is a very, very expensive law to implement because the vast majority of people who enter into a public exchange will receive a subsidy. For a family of 4, you can earn up to $92,200 and still be subsidized by the federal government. As you can see, with Medicaid expansion, there's a big blue question mark there because in Ohio, we haven't decided whether we're going to expand Medicaid or not. The governor is in favor of it. The legislature is not. So they're still battling over that. I don't believe it's going to get done in this budget, so we probably won't expand Medicaid at least this year. But as you can also see from this chart, a lot of us would be receiving a subsidy based on family income regardless of Medicaid expansion. So how am I going to find out and learn about the new health insurance marketplace or exchange? The law has given birth to this new concept called a navigator. I've been in the employee benefits business for not quite 25 years. I can't be a navigator, right? Because I can't earn a commission or a fee to place your insurance and then also be paid to help you navigate the exchange. I have to choose either or. So what we're going to have is the navigators that are entering into this business are folks that are coming from outside the industry. So not the most expertise because the navigator plan it's not a real lucrative plan for folks who advise. So you're going to see nonprofits, churches, organizations entering into navigators. I think it's going to be, if you think about the cable company meets the DMV for customer service, right? That's what the exchanges are going to be like. And you're going to need a lot of help. Health insurance exchange status, Ohio. Our program is going to be federal with state assistance, as we talked about. The single premium for a bronze plan, $282.51 is an estimate. As you can see, Aetna, AltCare, Humana, Medical Mutual all have agreed to participate. There are 14 insurers in Ohio who will participate in the plan. I don't know if you've followed what the president is saying, but he's actually telling us that costs in the insurance marketplace are going to be lower than they've traditionally been. That may be true in California and New York, where insurance is very expensive. It is not true in Ohio. Trust me, I deliver renewals to my clients every day, and these renewals are ranging from the low end in the 20s. I have a client right now who's gotten a 59% increase to their health insurance cost. So I don't expect it to be very affordable. The underwriting model is changing. We'll talk quickly about the underwriting model. So private exchanges, we talked about limited participation to date, but bigger and bigger employers are entering into these defined contribution private exchange marketplaces. Medicaid expansion. So the idea behind Medicaid expansion is that we would expand Medicaid to go 130% of poverty. Right now it's 200% for kids. So kids are insured inside a program called CHIPRA. There's not a lot of traction in the legislature. If you talk to the folks that are opposed to it, their concerns are around two things. One, it's going to put a lot more people on kind of a public assistance type health insurance program. They're not looking to expand the roles of folks who are dependent on our government. And then two, the Fed funding for the expansion is only a 2-year deal. So we could agree to expand Medicaid, do that, get Fed money for 2 years, and then the Fed money theoretically, depending on the economics of what goes on in the federal budget. Anybody confident we're actually going to have a federal budget? Things could change in a couple of years. So I'm kind of on the fence as well. Medicaid expansion is great for the hospitals and the providers. They need our help. But I don't think it's great for us as taxpayers because it could end up being an unlimited kind of wallet. At this point, Mario's going to talk a little bit about employment relationships, and then I'll be back.
Okay, thank you, John. It was great. I'm going to be focused on talking about when you have a large employer that's going to be subject to the penalty regime. Really what one of the platforms for this Health Care Act is to encourage large employers to provide health insurance. The idea, of course, is to cover more people. The government has seen large employers as a great place for coverage to be provided to a broad group of our population. So there's the first definition that's really important is whether or not you're a large employer. Now, even if you're a large employer, you may or may not be subject to penalties. You'd be subject to penalties only with respect to your full-time employees. So that's an important concept as well. And there's been a lot of confusion, probably rightfully so, about when you're a large employer and when the penalties apply. And I think some of that confusion is centered around part-time employees and seasonal employees, because all the hours of your employees are taken into account when you're determining whether or not you're a large employer. So that's, so you would take, and really, if you have 50 full-time employees plus full-time employee or full-time equivalent employees, that's going to cause you to be a large employer. I'm going to talk about that in a minute. But what I'm going to talk about now is really the penalty regime that applies. So we're going to assume that we're talking about a large employer that has 50 or more employees, and when penalties would apply. Now, as I mentioned, part-time seasonal workers, they fluctuate with respect to their hours, so at some point in time they could be a full-time employee. And for this purpose, 30 hours a week is considered a full-time employee. So as you can guess, sometimes you could have a worker that's seasonal or part-time that would be full-time employee for that week, and some other weeks they may not be. So that obviously is not very administratable. So what the government's done is that they've created some what are called safe harbors. And the safe harbors allow an employer, when planning for who's going to be covered by their policy, to use what's essentially a look-back period. And let me just skip right over to that. Oh, well, here. So how the look-back period works is that you look back some length of time, and the employer can adopt what length of time is appropriate. It could be anywhere from 3 to 12 months for current employees. So, and the question they're asking is, over that measurement period, did that employee work on average more than 30 hours a week? So you're taking the aggregate hours for that measurement period, and you're making that determination. And if the answer to that is yes, then on a going forward basis for what they call a stability period, they have to be covered by the plan. So it's a fairly straightforward approach. For new employees, the question's a bit different. Obviously, you don't have the history of work that they've done. So there's a question that has to be answered. If it's reasonable to assume that they're going to be working on a full-time basis as of the start date, then you have to treat them as a full-time employee going forward, and they have to be covered by the plan. On the other hand, you may be hiring part-time or seasonal employees, or you may not be sure whether or not they're going to be full-time. And the law allows you then to apply, again, a measurement period on a going forward basis before they have to be put into the plan. Okay, so there's testing periods, and then there's a follow-up stability period during which they have to be covered by the plan. So let's skip to this. So this is ongoing employees. And what you have here is there's really 4 options here, or 4 different scenarios. As I mentioned, on the left you see the standard measurement period. So this is really the look-back period. And again, this is the employer that is looking at their ongoing employees. And an ongoing employee is someone that's worked as an employee for the entire measurement period. So you have, in this example, 3, 6, 9, or 12 months as the measurement period. Now the employer can adopt any one of those. So and the idea is it's whatever is most administratively convenient or makes sense for the employer, that's the measurement period that they would adopt. There's a corresponding stability period. The stability period cannot be less than the measurement period. So as you can see, there's corresponding stability periods. The first example, if you have a 3-month look-back period or measurement period, you cannot have less than a 6-month stability period on a going forward basis. So in that instance, in those, and again on the left, we have 3 months during the standard measurement period. In one case, the employee is treated as part-time, so they would not need to be covered going forward during the stability period. But on the other hand, if they're full-time during the standard measurement period, they would need to be covered during the 6-month period. Okay, so that's how ongoing employees work. And what happens is this is a recurring event. So the standard measurement period begins again after it ends. So if we had, in the first example, a standard measurement period that ran from October 1st to December 31st of, let's say, 2013, our standard measurement period would again commence following that period. So as we go down to the 6-month, 9-month, and 12-month, there's also a concept called administrative periods that can follow the standard measurement period. And the idea there is that the employer may need time to do administration, to enroll employees. Once, well, you know, it's time to gather information, make the determination as to whether they're part-time, full-time, based on the look-back period. And then if once they've determined that they're full-time, to get them enrolled into the plan, or at least offer them enrollment, give them notices, that kind of thing. So you need, it's likely that there would be an administrative period that's necessary following the standard measurement period, and it could be up to 90 days, essentially. So you see the administrative periods there. And let's, you know, I think a common scenario is going to be the 12-month standard measurement period followed by a, let's say, a 3-month administrative period, which is the last example. And so what happens there is we have from October 1st to September 30th of the following year, we have our measurement period. We have the 3-month administrative period from October 1st to the end of, to December 31st. And then we have the stability period. So if during that measurement period, the ongoing employees are determined to be full-time employees, they're going to need to be covered during that stability period. Now what happens following the first standard measurement period, the standard measurement period again repeats itself. So it's an ongoing process. So as employees drop out of full-time employment or you add employees into full-time employment, they're going to need to be covered for the subsequent stability period. There would be a subsequent administrative period to get those employees enrolled into the plan. So that's how that all works with ongoing employees. For new hires, it's very similar. As I mentioned, if you have a new hire and it's reasonable to assume they're going to be full-time, they need to be covered immediately, or I should say there's a 90-day grace period to get them enrolled. And if you're not sure whether they're going to be full-time employees, again, it's 30 hours on average per week during your measurement period, or during, I should say, your coverage period. If you're not sure because maybe they're only going to work part of the year, maybe they're part-time, maybe they're not full-time all the time, you have again, a measuring period on a going forward basis. So again, there's flexibility as to what that's going to be, 6 months, 9 months, 12 months. During that measurement period, they don't have to be covered. But again, you need to make sure that you have at least some kind of reasonable basis to conclude that they're not going to be full-time employees when you hired them. I mean, you may not, I should say that in the reverse. That if it's reasonable to assume that they would be full-time employees, then you have to, you have the 90-day grace period. But if it's reasonable not to assume that they may not be, then you have this testing period from the start date going forward. Again, you have the administrative follow-up periods and then the stability periods. Okay? So that's really the crux of the process or procedure to determine whether or not you have full-time employees. And again, the key to all of this is that you want to make sure who you have to cover, because if you don't cover the right people or you don't cover enough people, then you could be subject to penalties. And the penalties are based on full-time employees that don't receive coverage. Okay. So, skipping over to the next slide, variable work schedules, I touched on that a bit. There's been a number of guidance or proclamations by the IRS regarding how to cover teachers. I guess teachers is sort of an example of someone that has a variable schedule. They have summers off, they have holidays off, spring break. So if you looked at that the year as a whole, as a calendar year, they might not be full-time employees. I guess if you do the math, it may not work out to 30 hours per week. But what the law says is that, essentially what it's saying is that if they look like they're full-time employees based on what they're doing, and it's really due to the fact that they're working for an educational institution that has an academic year, that you would really spread the hours out over those breaks, and then they become full-time employees. Commissioned salespeople, pilots. Pilots by regulation really can't work that many hours, so that's going to be something that's going to be addressed. But if a pilot is performing normal kinds of levels of service, just like anyone else who's regulated that can't provide can only provide so many hours of service, I think the government's going to look at that and deem them to be a full-time employee. Commissioned salespeople. The idea here is that a commissioned salesperson may not be working 30 hours a week. Maybe they're working a bunch of hours sometimes, but they're not working that many hours other times. But what's the key here is that the government wants the employer to take into account preparation, travel time, all the kinds of work that's ancillary to the actual performance of their sales activities in determining whether or not they've met the 30-hour per week threshold. So, all that's really to say, if you have someone with a variable schedule, you have to be, from an employer standpoint, you need to be, I think, conservative in taking into account the total number of hours they're actually putting into the job, and not try to be too fast and loose with that, with the idea that you take the position that they're part-time and you don't need to cover them, because I think that is going to be something that runs afoul of what the government's trying to accomplish. Independent contractors versus employee, this is just a historic issue where the government wants all workers to be treated as employees, basically, and a lot of companies don't want to treat their workers as employees because of payroll taxes, workers' comp, a bunch of other costs associated with having employees. And this is another cost. Now you have health care premiums that need to be paid by the employer. The government's using the same test, though. It's a 20-factor test. So to determine whether or not you have an employee versus an independent contractor, the main question with that is whether or not the employer has the right to control the worker. So and you see this really all over the place as well. I think there's a lot of cases in the construction or the contracting industry where contractors are engaged on an independent contractor basis. The government may challenge that because they may deem that those individual workers as being employees because the company ultimately controls what they do. So there could be significant exposure there. Leased employees are generally going to be treated as employed by the leasing company. And temporary staffing agencies, there's been a number of strategies, I'll call them, designed to kind of game the system where you would use a temporary staffing agency to hire workers for part of the time that they work for the company. And what the government has said is if you try to game the system in that way, shift the employment relationship to a temporary staffing agency, that's going to be looked as an abusive relationship, and they're going to ultimately treat the employer or the company as the employer for all those hours. Okay, so again, I think that the theme with all of that is, be reasonable, conservative with your determination of how many hours workers are working, and be careful about independent contractor status, and also be careful about shifting the employment relationship to temporary staffing agencies. Okay. Okay, so I mentioned large employers. That's who penalties are going to be imposed against if they're not providing health care insurance to full-time employees. So when do you have a large employer? As I mentioned, 50 or more full-time employees. It also includes a concept called full-time equivalent employees. And so the full-time employees, that's pretty easy to figure out because that's just 30 hours a week on average over the prior calendar year. So if you look at the prior calendar year, the work, and you determine how many full-time employees based on those hours. So in this example, we have 45 full-time employees. Those employees worked an average of 30 hours per week over the prior calendar year. Then we're looking at all our part-time employees, the ones that haven't reached the level of full-time. We're adding all of those hours up among all those part-time employees, and we're going to divide that by 1,560, which is really the full-time equivalent for a calendar year. So in this example, we ended up with 10 part-time employees. And because the reason that is because we had 14,500 part-time hours worked. I'm sorry. Is that?
Yeah, it's correct.
That is correct?
Yes. Divided by 1560, they actually, the law applies to them.
Okay, so yeah, my math is not sharp today. Okay, so if you do the math with a calculator, hopefully, then you would, in that example, you would have come up with 9 additional full-time equivalent employees, and you'd be at 54, in which case you would be a large employer and then subject to this whole penalty regime if you don't maintain health insurance for your full-time employees. Okay? So I think what's interesting about that is, and I think there's some confusion around this, is that you take part-time and seasonal employees into account in determining whether you have a large employer, but those same part-time and seasonal employees will not cause you to be subject to a penalty if you don't cover them. So that's, for example, the restaurant industry, they may have a lot of seasonal part-time employees that if you add all of those up and divide by 1,560, you probably have a bunch of full-time equivalent employees. But those same part-time and variable seasonal workers may not need to be covered because they're not full-time employees in and of themselves. So that's important. I'm going to skip that one. Okay, so I mentioned already about be wary of certain schemes to avoid these rules. So as a large employer, what are you going to do? I mentioned shifting workers to independent contractor status. You need to be very careful that if you're going to do that, that you're comfortable with the fact that you have an independent contractor status or relationship versus an employment relationship. I mentioned shifting workers to temporary staffing agencies, splitting up the companies. So this is interesting. So 50 employees is all you need for a large employer. What if you had 75 employers and you decided to split into 2 businesses? Would that work? Well, there's controlled entity rules or controlled group rules that apply. And if the same 5 or fewer owners own more than 80% of different businesses, 2 or more businesses, they're aggregated. So then those 2 businesses, because of that common control, would be treated as one employer for purposes of determining whether or not they're a large employer. So splitting up businesses and having common control doesn't work, shouldn't work. That rule has been around for a long time as well. Government's just really borrowed on what's already in the retirement plan area. So similarly with retirement plans, if you have controlled entities, those controlled entities generally have to cover a significant portion of all the employees of all those controlled entities. Affiliated service groups, this is a very similar concept where you would take the company, and you would split off, let's say, a chunk of the employees and put them into a separate entity. But those same employees, of course, provide services back to the company because they're basically workers for the company, or they provide service to the customers of the company. Either way, they're treated as an affiliated service group, and again, they're going to be aggregated for purposes of determining whether or not you're a large employer. And again, if you're aggregated and you're determined to be a large employer and you haven't maintained health insurance, that whole penalty regime is going to apply among those controlled entities. So, okay, I'm going to give it back to John now.
Thanks, Mario. Sure. All right, so we just heard about if you're over 50, the law applies, taxes, goofiness. Has everybody got that calculation thing, right? Pretty complicated. Do I have full-time? Do I have part-time? Are they temporary? Are they seasonal? Hopefully you got a really good payroll system that can spit out all this data for you, because you're going to need to really assess and understand. A lot of small employers say, well, thank God I only have 36. I don't have any part-timers, so that part-time equivalent thing doesn't work for me. This law, I'm off the hook, right? Well, not so much. So what happened as a part of the Affordable Care Act, we talked about the, if we read the base of the Statute of Liberty, the weak, the huddled masses, right? We've talked about the people who are already sick and they're not on an employer-based plan. They don't have anywhere to go. And this is the part of the law that I wholeheartedly 100% am in favor of, because I have a lot of folks who had ended up, because of an economy that caused them to be unemployed or because of their health status, they can't maintain full-time employment. Those folks many times are left behind. If they're under age 65, Medicare doesn't help them. We currently have a health insurance marketplace if you're an individual that is not mandatory coverage, right? So if I apply and I'm sick, I'll get declined as it is today. What the law now says is after January 1 of 2014, everybody is guaranteed issue, right? So no matter how sick you are, you could be literally HIV positive, stage 4 cancer, sign up for insurance, come on in. You're going to pay a similar rate to the healthy folks, because the other thing that they've now done is change the way health insurance is underwritten for small groups. So today, if you're a part of a small group, you fill out a medical application. Anybody ever used a form fire, right? There's an electronic online, you go in and you bare your medical soul to a machine, and then it spits out, okay, you're this sick on a scale of 1 to 10, you're 2 sick or 10 sick or somewhere in the middle. That's gone. What we now have is community rating, and today, where we have health statements and we rate on gender and age and geography, smoker status, Medical Mutual has 36 rating tiers. Tier 1 being that healthy marathon runner, young group, and Tier 36 being the, I wish we didn't really have to offer you insurance, but we do because Ohio Small Group Reform says we have to, right? So you could be somewhere in the middle. Well, after January 1, 2014, Medical Mutual is going to have 4 rating tiers, not 36, 4. And they're able to ask you really a few things. What zip code do you live in? What is your date of birth? Smoker status, guys, still on the fence because Ms. Sebelius and company decided that if you base your rates on smoker status, you have to provide something called a reasonable accommodation, right? What a reasonable accommodation is, if you smoke, is agreeing to participate in a smoking cessation program is a reasonable accommodation, and therefore you couldn't be rated up for smoking. You don't have to quit. You just have to say, I'll enter into a smoking cessation program. Now you can't upcharge me as a smoker. So most of the insurance companies have thrown smoker status out and said, we're not going to do that. The life insurance companies can still use smoker status, but the health insurance companies cannot. So what we're going to come up with now is, if you're a really young, healthy company with pretty preferred rates, you're going to be regressed to the same mean rate as that really old, sick company who has really high rates, right? So I'm going to guess not everybody has studied statistics, but you've probably all heard the term regression to the mean. Basically, everybody's going to go to a common rate, but because of the anti-selection issues that we've talked about before, that mean rate's going to move up substantially. The other thing we've got going on in small group reform as a part of the Affordable Care Act is we talked about those. There are 10 categories of coverage that must be offered: maternity, newborn care, prescription drugs. Some small group plans limit coverage today to keep it affordable. That's out the window. There's also a limit on deductibles. How many folks in the room have adopted a high deductible health insurance plan to keep your costs in line? How many folks have one over $2,000? Okay, that plan is no longer lawful if you're a small employer after January 1, 2014. You can combine your HRA, your health reimbursement arrangement, with your high deductible plan, and as long as the out-of-pocket doesn't exceed $2,000 single and $4,000 family, you're okay. But I have lots and lots of clients. We at the Fedeli Group, as a matter of fact, offer a $5,000, $10,000 deductible plan to some of our employees. That plan will no longer be lawful after the first of the year. So let's talk a little bit about affordable and kind of where we're going to keep these costs in line. I'm sure a lot of you have considered and maybe have implemented wellness programs inside of your employer plans. Many of those wellness plans have evolved into saying, okay, not only are we going to have a wellness plan and we want you to participate, but we're now going to base your rates on your overall health status. That's okay. That was actually allowed under HIPAA. It's been clarified under the Affordable Care Act, and we now have final rules with regards to tobacco prevention. But again, kind of like many things the federal government does, they gave it to us and said, smoker status, we really want to make those smokers pay more, but we're going to take it back because now we're going to give them a reasonable alternative. So, but I do have a lot of employers who say, okay, if you have a high BMI, if you have poor cholesterol, if you have high blood glucose, you're going to pay more for health insurance than someone who's extremely healthy and on our plan and manages their health better. That is allowed by law. It's discriminatory, highly discriminatory, and it's allowed by law. The differential in rate, if you include smoker status and provide a reasonable accommodation, can be 50%, right? So that really healthy employee could pay $100 a month, and the employees who's not so healthy could pay up to $150 a month, 50%. We have participatory plans versus health contingent plans. We didn't really have legislative action on that health results related plan. We now do. It's called health contingent. And as you might guess, there's a whole litany of regulations you now have to follow if you're going to have a health contingent plan. Who's heard of a company called Bravo Wellness? I'm surprised. They're a local Westlake-based company that's got national acclaim because they kind of wrote the book on these health contingent plans. Those folks know the regs very, very well. We use them many times with our clients. But I will tell you that you see these 5 rules listed there for reward-based plans. It's becoming increasingly difficult to stipulate contributions based on health status. Many employers, I work with a large hospital system down in Summit County, they've abandoned their health contingent program because of the reasonable accommodation rules. Wellness that works. Well, again, I think we all agree, and I said a part of my call to action to you before we finish today is personal responsibility. I think we all agree that we should have programs that promote the overall health of our employee base. And I think we all as employers want our employees to live happy, healthy, productive lives, not be sick, not be morbidly ill. But there's kind of a balancing point between being big brother, right, telling your people how to live their lives, don't smoke, be skinny, eat the right foods, versus all the regulatory issues involved with challenging our employees to do that. So I think we're going to continue to fight that battle, and we talk about that in our wrap-up remarks. The other thing that we're going to see a lot of, so we talked about that young healthy group. That young healthy group is probably looking at a similar rate increase to the older sicker group. Many of them are going to say, wait a minute, what are my alternatives? We're going to see a growth in the self-funding of employer space. What does that mean? Employers will bear risk where they hadn't done that before. As it exists today, if you have less than 100 or 150 employees, it doesn't make great sense for you to consider self-insuring. But because of the growth of entities like healthcare captives and stop-loss insurance companies coming way down market, now if you have 20 or 30 or 40 employees, self-insuring will be an option for you. So if you're not talking about that with your employee benefits advisor, you ought to start, because there's going to be some new opportunities for you to self-fund to keep those costs in line. Other reporting and compliance requirements, we got all kinds of them. W reporting under 250 employees was delayed, but the idea of that is, as we prepare in 2018 for the Cadillac tax, we need to know as the federal government what's the value of your health plan, so W-2 reporting is coming. Everybody should be familiar at this point with something called an SBC, a summary of benefits and coverages. The federal government thought that this is an amazingly complex business, and they thought that the SPDs, or the summaries of benefits that we were giving out to our employees, were too complicated. So they decided in their wisdom the size of the font and the format upon which all of the communication pieces should be, and the language has to be in very simple, plain English. It can't be in any sort of legalese, in deference to our legal friends here. So the SBC is something you should have distributed last year. If you didn't, please do. It's a regulatory requirement. Notice the coverage options. Again, guidance is coming. We got some guidance on the 18th of May. Non-discrimination, we talked about that. Control group statutes are being applied. So again, to Mario's point, you can't have a 100-employee group and split it into 250s. If it's commonly owned, it's one employer. Additional IRS reporting. Grandfathered plan notice. Does anybody still out there have a grandfathered plan? All right, congratulations. Those are dying a pretty slow death. Used to be there was some pretty significant advantages to staying grandfathered. Today, most of those are gone. So what is this? This is what is your situation. For those of you in the room that are Fedeli clients, and I know there are a couple of you here, in the front row, I think, we're doing something called a situational assessment. And what that is we're asking you for a whole lot of payroll type data, wages and hours, all that kind of information, so we can sit down and take you through a process to tell you exactly how this law applies to you in great detail. So you can make strategic decisions on future hiring, future staffing. Are you going to sponsor benefits for folks that you haven't sponsored it for before? Are there other alternatives? What funding mechanism might work well for you? If your current advisor has not done that for you, I would encourage you to call them to do it or find a new advisor, because you need to really take a very hard look, regardless of whether you're a 2-life employer or a 2,000 employee employer. This law is going to impact you, possibly substantially, possibly not. Here we look at some industries and how they're going to be impacted. Red would be highly impacted. White, light blue would be not very much impacted. Again, I'm a part of the financial services insurance industry. Not a lot of impact for us, because we're going to continue to sponsor the plan we've always sponsored. Again, the legal and professional services folks, again, to attract and retain the best, the brightest, so we can do the greatest work we can for you. We're going to need to continue to do this. Again, in the technology and software space, we got a lot of young folks in that space. But as you can see, retail, hospitality, food service. At Fedeli, we have 3 significant industries that we represent: construction, food service and hospitality, and healthcare. All 3 of those industries are massively impacted by this law. Healthcare primarily on the payer side. Your situational assessment should look at things like affordability. Is my plan affordable to my employees? Does it offer minimum value? Do I have to apply for the automatic enrollment provision? We see question marks there because the jury's still out on that. Part-time variable hours, Mario talked about. Very, very detailed discussions need to be held on part-time variable hour. And then which taxes apply to me? Depending on if you're self-insured or fully insured employer, some of these taxes would apply, but we're talking about things like a reinsurance fee, a PCORI fee, an insurer fee. We're going to hear from our friends in the accounting profession now to talk about how are we going to generate enough revenue to pay for this massively expensive law.
Thanks, John. Appreciate it. As John mentioned, we're going to focus on the revenue generation side of the Affordable Care Act. As you can see on the slide, nice bar graph we put together. More than $400 billion in new taxes and fees are expected to be collected between now and 2019 to help pay for the health care legislation. Specifically, I'm going to focus on the first 2, the Medicare unearned income tax and the Medicare payroll tax. As you can see, that comprises over half of the expected revenues that are part of the Affordable Care Act. I'm going to talk about what those taxes are, who's primarily going to be affected, as well as discuss a couple ideas and thoughts about how we might be able to avoid or mitigate some of those tax liabilities. First off, what is the 3.8% net investment income tax, unearned income tax, Medicare surtax? It's called a couple different things. But basically what it is, it's a 3.8% tax on investment income, okay, of individuals, trusts, and estates to the extent they have income over certain statutory threshold amounts. This is a surtax. It's in addition to regular tax and AMT liabilities. So you compute your regular tax liabilities you normally would, and then do the separate calculation based on your net investment income to determine whether or not you owe the 3.8%. It also is subject to estimated tax provisions, and this is effective for 2013. So if you, or I know we have some CPAs in the audience as well, or your clients are affected by this new tax, you really should be looking at your withholdings or your estimated taxes to see if some adjustments should be made so you have adequate amount paid in to avoid any penalties. I just did actually a tax projection for one of our clients And we took their 2012 tax situation, literally just sort of flopped it into 2013 initially, did our projection, and this tax alone was a $25,000 increase for that particular client. Bear in mind, it's a high income earner and also had a high portfolio as well that generated a lot of investment income. But for them, $25,000 is a big item, and we need to do our best, obviously, to see if we can mitigate that. Moving along, how's it calculated? It's 3.8% of the lesser of net investment income or the excess of MAGI, it's called, but basically it's adjusted gross income over a threshold amount. The Congress has established thresholds based on filing status. As you can see, based on those values, this 3.8%, and we're going to talk about the Medicare payroll tax as well. Both taxes are really geared toward, I wouldn't say necessarily wealthy individuals, but definitely upper middle income class families. So married filing joint, 250,000 is the threshold, single 200,000, so on and so forth. I'm going to go through a quick illustration to kind of highlight the main fact that in order to be subject to the 3.8% tax, you really need to have net investment income and your AGI has to exceed the threshold amounts. If either one, if your net investment income is zero or you don't exceed the threshold amount, you're not going to owe this tax. Example one here, during year one, Brendan has AGI of $190,000. He's unmarried, so he's single. He also has $50,000 in net investment income. Because his AGI does not exceed that statutory threshold amount of $200,000, he will not owe the 3.8% tax even though he has $50,000 in net investment income. Okay? In year two, let's assume that his AGI is $220,000. He has the same $50,000 in net investment income. In that example, because his AGI goes over the threshold of $200,000 for a single taxpayer, he now is going to have the 3.8% tax, and it will be the lesser of the amount at which that AGI exceeds the threshold, in this case $20,000, or $50,000 is net investment income. So 20,000 times 3.8%, 760 bucks. So that's basically how the math works with respect to 3.8%. What's included in net investment income? Interest, dividends, normal portfolio income, royalties, rents. There is exception to that. Rents by default under the code is considered to be passive income and would be net investment income for purposes of this tax. But a lot of times we'll have clients that are actively involved in real estate activities, residential real estate, residential rental real estate, commercial real estate, and if their activities rise to the level of being considered a material participating real estate professional under the code, that income, otherwise passive, could be converted to be non-passive and not part of this tax. Passive activity income is an interesting one. This one, it really relates to owners that have ownership interests in passive entities, investment partnerships, or if they have an individual that's silent, not active in a business entity, an S corp or LLC. That income that flows through to them would be, if it's treated as passive income under the law, it's going to fall into the 3.8% bucket. Excuse me. Capital gains also is going to be part of what's included as investment income. What's excluded from the investment income bucket in terms of this calculation? Active trade or business income. So any closely held businesses, owners and S corps, partnerships, sole proprietors, folks that are out there working hard to help pay for these taxes, your active trade or business income is not going to be part of the net investment income tax base. What's interesting is the proposed regs under Section 1411 actually talks about working capital. So if you've got a business and it's very successful and you've got excess working capital dollars that are being invested in marketable securities or just put aside in a money market account and is generating portfolio income, the regs hold that working capital investment income actually is considered to be passive income even though you're involved in active trade or business. So that income would flow through to the partners and be treated part of the tax base, which I thought was quite interesting. But again, they're proposed regs and these things continue to evolve, so we'll see what happens when the regs are finalized. Distributions from qualified plans or IRAs are not investment income. Any self-employment income would be excluded. And to the extent you've got an interest in a working interest in oil, gas, property, that also would be excluded from that bucket. And it's important to note that any income that's otherwise excluded under the tax code is also going to be excluded from this net investment income tax calculation. Some ideas or thoughts potentially to mitigate or maybe even avoid the 3.8%. All these ideas, quite frankly, sound great, but you really got to sit down, look at your relative situation, look at your investment portfolio, what makes sense in terms of where you should be allocating dollars, and it doesn't make sense for you financially. Do you have the cash flow to do some of these things? But tax-exempt bonds, clearly muni bonds, it's tax-exempt income, so obviously it's not subject to regular tax, and it also reduces your AGI threshold. As we looked at that calculation, not only reducing the net investment income bucket is important, but also reducing your AGI on an annual basis to the extent you're near that threshold amount can help reduce this tax. Looking at installment sales, again, taking that, any sale proceeds and the relative gain related to a sale of property or even a business interest and spreading that over a period of time not only allows you to defer the income tax consequences related to that, but also will allow you to control and manage your AGI limits too as well for the 3.8% tax. Look to make Roth IRA conversions. I historically have not been a big fan, not usually been a big fan of Roth IRA conversions, but in this situation, again, because the distribution from qualified plans or IRAs are excluded from the definition of investment income, you make that Roth IRA conversion, you got the ability to obviously grow the investment on a tax-deferred basis, tax-free basis over time, accumulates, and then when you take that money out, obviously it's going to be tax-free income and not part of the AGI calculation the year you take that money out. Roth IRA conversions, we'll look at those in the context of maybe we've got a business owner that has a business loss coming from an investment, or even some older folks that are lower taxable income brackets. If we can convert that Roth IRA and not create a huge income tax event in the year of conversion, we definitely look at it. Purchasing life insurance. If you're a business owner, have partners, if you don't currently have life insurance in place to help fund buy-sell arrangements, or quite frankly, if you just don't have life insurance in place for your family, it's something that makes good sense to do from a business perspective and from a personal perspective. But when you're looking at those products, it's just important to note for purpose of this presentation, any inside buildup, any variable whole life policies would be tax-free, not included in the base, and as well as any life insurance proceeds, obviously, in the event of death, God forbid. That also would be excluded from regular taxable income and not part of the AGI threshold calc. This one is a real simple one. If you're at that threshold level, and you're looking to adjust your AGI to get beneath it. Fully funded 401k and retirement plans. Whether you're an individual working for somebody and you haven't maxed out your 401k contributions, or if you're a business owner and you don't have a retirement plan set up, or you have it set up and you haven't fully funded it. In this tax rate environment, it makes good sense to put money away on a tax-deferred basis, let it grow tax-free, but it's also going to reduce your AGI in the year of contribution, the year of the deferral. So again, depending on your specific situation and where you're at from an AGI standpoint, you're also going to get the benefit of 3.8% as well. The example pretty much just illustrates some of the things we talked about. Moving forward to the Medicare payroll tax. Prior to 2013, all compensation, wages, and self-employment income is subject to the 2.9% Medicare tax, and there's no dollar limit in terms of how much that income is subject to it. Beginning in 2013, that 2.9% rises up to 3.8%. Okay, and in addition to that, and as we'll talk, it's based on threshold amounts as well, very similar to the net investment income tax calculation. But unlike the 3.8% tax, employers are actually involved in this 0.9% Medicare payroll tax. And this, again, applies for this year. So if you've got employees that are earning wages or compensation in excess of $200,000 this year, you're required to withhold another 0.9% on that income. And that obligation exists regardless of whether or not that individual actually owes that tax when they file their return. As we'll talk about when we look at the thresholds, you could have a married filing joint couple that have AGI under $250,000, but say the husband works and the spouse and the wife does not, or vice versa. If that individual makes $230,000, employers is required to withhold the 0.9%. When they go to file their return, they won't actually owe it because they're under the filing threshold. So that tax that got withheld will be obviously creditable against any other tax liabilities that individual has, or it'll get refunded. So real quickly, here's the same graph we had before. Again, you can see the target group in terms of where these taxes are going to come from. They're going to be folks that are making a little bit more money than your average middle-class person. But by all means not, extremely wealthy individuals. Last comment I want to make with respect to this Medicare payroll tax in terms of the self-employment income piece is, we have a lot of clients that are closely held businesses that have multiple business interests. Some are profitable, some aren't profitable. And when you're calculating this 0.9% Medicare payroll tax, you're going to aggregate all that employment, that self-employment activity. In addition, sometimes we have clients that have suspended losses, due to basis limitations otherwise, sitting in some entities. Does it make sense to potentially look to trigger up some of those losses again to help mitigate some of this tax going forward? Quick example, Jay, partner in a partnership, also has a separate business. He's a sole proprietor, has $300,000 of income from the partnership and a $50,000 loss from his sole proprietorship activity. As I just mentioned, net the two, If he's filing joint, he's at $250,000, he wouldn't owe the 0.9% tax, whereas if he didn't have that $50,000 loss, he would owe it on $50,000 of his self-employment income. Last slide for me, and I'll hand it back to John, deals with just entity selection. Given this 0.9% tax, we're often asked the question, you know, what entity should we be? What should we choose? Should we be an S corporation? Should we be a limited liability company? And it really depends, as always, on the facts and circumstances. You know, are there multiple partners? Do we need to have flexibility in terms of how we share profit and losses and how we take money out of the business? If the answer is no, and I've got a 100% shareholder that's really not looking to bring on any partners anytime soon, you know, S corporation usually is the route we go. In an S corp environment, that amount of income that an owner earns above and beyond the wages they take from that business, it's not self-employment income under current law. So whatever that number is, and the bigger the better, it escapes the 2.9% prior to this year, now 3.8%. So, you know, depending on facts and circumstances, I think that, you know, the argument for S corporation is a little bit stronger today. Last item, bullet point there, though, is there has been activity. There's been proposed legislation in the past, and there's activity now talking about subjecting that K-1 income for S corp shareholders to the self-employment tax. In the past, it's really been in the context of personal service S corporations, but, you know, the way things are trending, I wouldn't be surprised if they close that loop as well. So if you or your clients, I know we have some CPAs in the office, if you or your clients are in the $200,000, $250,000 range, these specific taxes under the Affordable Care Act are going to impact you in 2013. I would encourage you to talk to your advisors and make sure that they're taking your situation and running some analysis and determining whether or not there's things you can do to potentially mitigate or avoid some of the impact. I'll give this back to John.
Thanks, Mike. Being sensitive to your time, we're going to wrap up pretty quickly here. I think you just heard those folks at the upper end of the income spectrum are going to be targeted at this point to pay for the law. I think, again, every time you see the president on a soapbox, he's talking about that hasn't impacted individuals, the law. It's really impacted high-income individuals. But if your health insurance as a person who earns $30,000 or $40,000 a year used to cost $200 a month and now it costs $400 a month, I think that's an impact. Additional taxes and fees, we're going to be seeing things like PCORI, we're going to see reinsurance fees. Most of those are borne at the employer level. There is an insurer fee that's being allowed the insurance companies because of that anti-selection process that we talked about earlier, more sick people joining the rolls of the health insured. The insurance companies are allowed to apply for and be reimbursed from a reinsurance fund that employers are paying for. The manufacturers of drugs and medical devices are also being targeted, so they're going to be paying additional taxes. Where are those taxes going to be borne? Well, if they're putting a hip implant and they had to add $200 more onto that hip implant for taxes, where do you think they're going to get that $200? They're going to get it from you when you get that hip implant implanted into your body. What I really want you to just understand is that we do have a very, very complex ecosystem in terms of the Affordable Care Act and who is impacted. I don't know if any of you have physicians or hospital administrators in your families. They have a lot of consternation about this. The Cleveland Clinic alone is projecting $1 billion of reduced reimbursements, $1 billion of reduced reimbursements over the next 4 years due to the Affordable Care Act. So again, providers are very, very concerned about this. Last quick talk. Many of us in the room are heading towards Medicare at some point in our future. Obviously, the date at which we qualify is going to be subject to change depending on what they do with Medicare. But there's a ton of impact on Medicare and ACA. As I talked about earlier, many of us who are getting our health insurance today paid for by our employers are going to end up in Medicare sooner as opposed to later. We have this massive bubble in our society called the baby boomers. I'm just on the very tail end of that, not quite a baby boomer, I'm a kind of tweener, but many of us in the room are baby boomers. What we see here with Medicare, and we wonder if Medicare is sustainable because of the amount of increased expenditures. From 2006 to 2012, Medicare's expenditures went up $170 billion. The projection for 2020 is that Medicare expenditures will exceed $1 trillion. Right now, $574 billion. Because of those baby boomers. So again, how is Medicare paid for? We just heard from how is Medicare paid for. It's a tax. There's going to be massive increases in tax to maintain the viability of Medicare. How are insurers? Again, we talked about this. There's 32 million insured Americans. with an individual mandate, so we're expecting a large number of those people are going to enter into the, there are loss ratio mandates for the insurance companies now, something called MLR. The insurance companies actually have to spend a certain amount of the money that they take in on actual care delivery as opposed to administrative costs and profits. Again, anytime you hear the president talk, he's going to talk about the $200 that somebody got as their rebate. Well, they spent $5,000 last year on health care and they got $200 back. I don't know if that's a good deal or not. Accountable care organizations. Anybody who hasn't heard of an ACO, it's coming. So the way we do healthcare today is we do fee for service. That's why we talked about the imaging problem, right? We do deliver a lot of MRIs and CAT scans because they're expensive. It's easy to justify. Health insurance companies pay for them. The age of fee for service is going to be replaced by something called an accountable care organization. Doctors and hospitals will be responsible for a group of patients, a population of patients, to maintain their health status. Gosh, guys, it sounds a lot like an HMO, doesn't it? And didn't we live through that, and didn't that die a pretty quick death when folks didn't want narrow networks and being told who and what doctors they could go to? So an ACO is going to be a payment mechanism similar to an HMO. More to come on ACOs, but we're going to see a lot more of those. So what are the predictions? Well, certain industries are going to pay substantially more for healthcare. We talked about that. Our friends in the hospitality business are squarely in the target of this because they got a lot of variable hour employees. They got a lot of issues. Folks in the food service industry, same. Folks in my industry, not so much impacted. Exchange penetration is going to vary based on the states. You know, right now the model is Massachusetts. They went to an exchange many years ago. Much of the law was modeled after that. Right now, Massachusetts only has 4.7% of their population in the health exchanges. So do we think we're going to have 20% in Ohio? Probably not. There are going to be new partners, new consolidation. You're going to see more folks, collaboratives, where the accounting professionals and the legal professionals and the insurance guys get together to try and create some creative solutions. Self-insurance is definitely going to increase. Entities that never bore risk before for healthcare are going to bear risk. Movement from risk selection to improving outcomes. What does that mean? Well, that's my call to action for you, right? About 80% of what we spend in America today, 80%, is spent on preventable or manageable health issues. Cardiovascular disease, diabetes, obesity. All of us have a responsibility in this room to minimize that, not just for ourselves, but for our employees. And it really isn't that hard to modify your health in just some really minor ways, and that spend will change a lot. So my call to action for you as employers, create programs where your employees can improve and maintain their health. As individuals, do the best job you can to maintain and improve your health. There's only a certain amount of resources that we have in our country to deliver health care to Americans, and if one or more of us absorb too many of those resources, there's not going to be enough to go around. We are looking at physician shortages. We're looking at hospitals consolidating or closing. We're looking at healthcare in America. It's going to change pretty radically over the next 15 years. So I would call each of you to do your small little part to manage your health, take personal responsibility, because we are going to have new patient delivery models. We're going to be working inside of ACOs. Relationships between providers and employers are going to change. The insurance companies are going to be moved out of the way. I'm actually working with some healthcare providers today, hospital down in Summit County, that's going out and talking to the local CEO community, saying, hey, why don't we form a partnership and get Medical Mutual out from in between us, right? So there's going to be some very, very evolutionary and revolutionary things happening, and the model is going to be disruptive. So batten down the hatches. At this point, I know we're a little tight on time. We got about 4 minutes until you all can go, but all four of us be happy to take any questions that you have. So with that, I'll open it up.
Well, again, it's I mean, the question is, if you have someone, a commissioned salesperson that, you know, whether or not they would be treated as an independent contractor. And the fundamental question is, under the law, are they an independent contractor versus an employee? You can label a worker an independent contractor. You can enter into a contractor and agreement, but if ultimately the company controls the way in which they're doing work, schedules their work, you know, follows what they're doing, tells them what appointments to go on, they begin to look like an employee. So it's a difficult question to answer, not just up on this podium, but it's a difficult administrative question for the government to tackle because it's so factually intensive. But if you did the analysis, I mean, we're happy to take a look at those kinds of questions and give you opinions on that. And the government looks at a 20-factor test, and if it looks based on those factors as if they're truly an independent contractor, then you're good. I mean, they don't need to be covered.
It's an annual tax based on the investment income that's earned during that calendar year. So, and it's aggregated, that's right, correct.
Question for Mario. Yeah. How many IRS agents are being transferred from income tax audits to this area?
Oh, I am not sure what the answer, I'm sure they're going to be doing a lot of training and devoting resources, but I don't know what the precise number is.
DOL has hired 15,000 new examiners, 15,000 nationwide. IRS has hired 14,000 new, and estimates are 5,000 transferees. So roughly 30,000 more regulators to make your life difficult.
There you go.
Is the 9.5% of your income for health insurance costs, is that for single coverage or family coverage?
That's a great question. It is for single coverage. As an employer, the mandate of affordability is based on the single insurance plan. So if you want a strategy, it may not be a great strategy for your employees that have wives and kids or husbands and kids, but you don't have to make any contribution to dependents. That contribution is only based on the single plan. That is true. Well, there's not going to be a penalty tax on you or your firm for not sponsoring an affordable minimum value plan if you're under 50. And again, be cognizant of that part-time, full-time, because part-timers can count towards full-time. So if you're on the bubble or on the edge, you need to do that calculation. There are additional taxes and fees that are levied all the way down to 2 employees. So the PCORI fee, the reinsurance fee, all these income taxes that we talked about, doesn't matter how big you are. So as we said, even though you may be a small employer and think the law doesn't impact me, it does impact you. No, under 50 is where that impact is going to be the greatest. So small employer plans, the maximum deductible allowed for a fully insured small employer plan without an underlying reimbursement is $2,000 and $4,000. So if you have a higher deductible, but you're reimbursed through an HSA or an HRA, you can have higher deductibles as long as you buy it down to the 2.4. Again, all subject to what's going to be available in the marketplace. Most of the insurance companies are going to abandon those really high deductible plans in the under 100 marketplace.
I thought this was, beyond my expectations, extremely informative, a little bit scary at the same time. I want to thank you all for joining us, and especially I want to thank the panel for the presentation. It was excellent. CPAs, don't forget on your way out, grab your certificates, and again, thanks for joining us.
All right.